welcome back to the channel. We're doing another knee. We've been seeing a knee every day just in our GP clinic this week. People with terrible sore knees, arthritis, sometimes on the waiting list to get a knee done. Sometimes, as in this case, not really a candidate for a knee replacement. So we still pop a steroid in the knee, a bit of depomedrol with some local. And it's good to show you a few of these because some of them go smoothly, some not so smoothly. So I don't know how this one's going to go, but we'll have a look and we'll see what we see on the scan. Just going to put some, just sort of cleaning up the knee a little bit. Put a bit of gel on. You remember from the last video, you don't have to use sterile gel. I happen to have plenty, so I'm using it. As long as you don't put the needle through non-sterile gel. Often you just put the gel on the knee and then the scan on the gel, and the scan and the gel are far from where I'm putting the needle in, so it's still a sterile technique. And we've all seen our orthopedic specialist colleagues just put a bit of a quick alcohol wipe and pop in the steroid. We're a little bit more careful here. We put a bit of betadine on the skin, and we do a no-touch technique once the betadine's on. I just use a 25 gauge needle. Normally find that I can see that on the scan pretty well. I get a flash scanner. You might not have such a flash one where you are, so you might need a slightly different, even slightly bigger needle, but usually a 25 is okay. And we just sort of have already talked to our patient, saying what we're expecting to do. And if we just have a look on this, I'm just going to go longitudinal first. We'll get our bearings. If you look at the screen there, thanks Maggie for doing the filming. Then you'll see on the right hand side of the screen, that's the kneecap under the skin. And we just got to go a bit superior to the kneecap. Then you've got the quads muscle, and then deep to the quads muscle, you'll see that black area, that's the effusion. Most people with decent arthritis have a little effusion. Now I'm just going to go transverse. If you just have a look at the knee again, Maggie. So just going transverse, just above the kneecap. All right, and then I'm just going to go backwards and forwards like that and just check where the fluid's lying. So let's have a look back on the screen. So that's sort of in the middle. You can see the sort of patellar notch there on the femur. If we go a little bit laterally, there we go. So you can see fluid everywhere there. Let's just get a good pocket. Yeah, see that fluid there? And I'll just point it out a bit. That's the fluid. There's the synovium, it's all swollen. And then we've got the, the muscle up above that. Maybe a fat pad in there as well. So that's our target. It's quite a big target, and we're expecting to come in from the right-hand side of the screen and just pop the steroid in. So, anyways, could you just maybe explain, just feel a little sting in the skin here.
Jadi kita rasa sedikit pedis sedikit mana, kalau dimasukkan injeksinya tu ya? Iya. Okay.
Yep. So if we just have a quick look at where we're going. So usually, I just do this with people sitting. Right, sitting down is often people are in their position of comfort, and you can get a great view, and you can just sort of slip it in plane. So I'm in plane with my scan, and as it goes through the skin, we'll start watching it on the screen.
Okay.
All right, yeah. So let's go back to the screen. That's it. Find a big pocket that's, trying to find somewhere that's reasonably close to this. And you'll always know how deep it is because of the depth measurements on the side of the screen. Little bit of injection coming up. Don't move, that's the way. Sorry, yeah, very good. Hey, well done. Agus. Oh, we're going in from the other side, so I've got this will happen. You'll have your transducer around the wrong way because you're distracted. That's all right. We can just keep an eye on that. So we're looking from the left-hand side of the screen now. if you have your needle at too great an angle, you won't see it because the ultrasound beam needs to bounce off more or less as close to 90 degrees as possible. So sometimes when I'm in this situation and I can't see the needle, I need to flatten it out a bit in order to be able to see it. So you can see it's there. There it goes forward. See, I'm kind of missing my target a wee bit. So we're going to actually start again. So I'm coming up, and I'm just going to come in from a slightly lower angle. Sorry, one more sting. One more sting.
Hi.
Well done. Bagus.
Bagus.
Yeah, sorry. Oh, very good. So there's our needle. That's right. It's a bit uncomfortable going through the synovium there. That's in position there, so we can inject there. And you can see some steroid and bubbles going in. Just ensure that you're in the spot. That's it. So that's made that effusion look slightly bigger. We just got a little bit to go. That's perfectly comfortable now. A little bit of air at the end, see that bright colour? And we're just coming out now, so that's all finished. Habis, sudah habis.
Sudah habis, Wan.
Sorry, sedikit sakit. A little bit sore. So that's so that's kind of the reality of scanning. Yeah. So get your orientation, make sure you know which side of the screen your needle's likely to be coming in on. Follow it into the space. You can see how using a scanner is so much better than trying to do that blind, because it would be very easy for you just to pop it into an area of synovium or an area where there wasn't a collection, and especially noticeable when there's not such a big space there. So I think, let's get used to always looking at these things under scan, and by the time you've done a few, it's just as quick or even quicker sometimes than trying to do them just using the old anatomical method. Thanks for watching. We'll see you again next time.